Now, here's a question that I don't have any answer for. I don't know if you would, Justin. How do EGFR fusions, such as EGFR-RAD 51, react to current treatment options?
Great question. I think Christine Lovely would be the expert on that. I think she had a cancer discovery paper, let's say 6 years ago, on EGFR fusion. I think that the important thing when you talk about fusions is knowing whether it is actually a functional fusion. And so let me give you some context there. So a fusion is a different type of genetic change. Many of the mutations that we've been describing are basically substitution, so switching one, an A for a B, things like that. A fusion is actually where a big piece of DNA breaks off and basically comes back together. So it's a rearrangement of the DNA. But for most fusions to really, fusions that then respond to drugs are typically fusions that enhance the activity. That is, when it recombines, suddenly the normal control of signaling are lost, and it is constitutively active. That is, it's always sending growth signals. Those are the types of alterations that are most likely to respond to targeted therapies. So my recollection is that Dr. Lovely had a paper years ago on EGFR fusions. My recollection is that these are incredibly rare, and I think this would warrant a conversation with my molecular colleagues. I think that's the other piece, which is as oncology has gotten much more complicated, as our sequencing panels have gotten much more complicated, it's really imperative for everyone to communicate with one another and talk to a molecular pathologist and get a sense of whether it's functional. If it's functional, I would consider an EGFR inhibitor, though I probably wouldn't do it as the first line of therapy.
Right. Yeah, that there's, as a general principle, that there's things that are worth trying, but that doesn't mean you'd supplant the well-established treatments. That you'd have a different, higher threshold and need more evidence to replace something that's a clearer standard.